Hello and welcome to our special virtual Q&A on the new medication Kisunla. I am Melissa Long, the Director of Education Support at Insight Memory Care Center. We will be working with Dr. Jennifer Pauldurai, going through some important information regarding this new medication, and we'll do questions after. Dr. Pauldurai is a specialty care physician and board certified in neurology and board eligible in neuropsychiatry at Inova Health Systems. She joined Inova in 2023 and has been practicing since 2019. Prior to joining Inova, she was a behavioral neurology and neuropsychiatry fellow at LaRuvo Center of Brain Health in Cleveland Clinic in Las Vegas. Her clinical areas of interest include memory disorders, dementia syndrome, behavioral disruptions, including hallucinations and delusions, and mood disorders in the setting of neurodegenerative disease. So without further ado, I'd like to welcome her, and we will go ahead and get started. Thank you for being here.
Thank you so much for having me, Melissa, and thank you all for joining us this evening. I appreciate that you are taking some time to learn more about Alzheimer's therapies. I'm going to share my screen. I do have a couple of slides for us. It hopefully is not too much science. I want it to be a springboard for questions for later, okay? So let's just make sure I can get this up okay. Does that look okay, Melissa?
It hasn't come up yet. Yep. So if you would
let's make a big screen. How about that? Are you seeing presenter view?
We're seeing the presenter side, so flip it. Yeah.
Okay, how about that one?
It's taking a second. There it goes. You got it. Perfect.
Perfect. Technologically challenged. All right. Well, I'll jump right into it. Thanks for the very kind introduction, Melissa. My name is Jen. I'm a cognitive neurologist. That means I help with diagnosing and treatment of Alzheimer's disease as well as other causes of dementia. Today we're going to talk about Kisunla, which has been all over the news since July. But before we jump into the treatment, I do want to make sure that we all understand what Alzheimer's disease is and how to best diagnose it, because it's only for Alzheimer's disease. And if we haven't proven Alzheimer's disease, then it's not even worth thinking about. So let's get into it. Now, Alzheimer's disease is diagnosed by a clinician who uses biomarker data, and biomarker pathology means what is actually going wrong structurally in the brain. And we combine that data with a clinical syndrome, okay? So Alzheimer's disease has to have amyloid plaque and tau tangles. These are two toxic waste products that build up in the brain as part of the disease process. Now, it's just the two bad guys we're picking on, but we know that Alzheimer's cannot exist without those two bad guys. Now, tau tangles are a little bit further down in the cascade of disease that happens. You'll notice that amyloid itself can often be a normal byproduct of normal brain activity. It's kind of like exhaust from an exhaust pipe from a car, okay? But once those amyloid particles start to clump together, then they clump some more, then they start forming these sheets, it can actually affect the brain cells and cause brain cells to die. That's where a lot of the tau tangles come from. But that's just two pieces of the puzzle. What we know about the amyloid cascade or storm is that it's also associated with glucose changes. Sugar is being metabolized differently. The way that the brain is responding to infection and inflammation changes. All of the blood vessels that are supposed to be delivering blood and nutrients to that area of the brain change. So it's a whole storm of changes in the brain that can lead to structural damage. So I think this is important to understand because a lot of people think Alzheimer's is something in the mind or something kind of made up or psychological, and we can't really see it because a lot of people are told that their MRI was normal or that there isn't a good way of diagnosing Alzheimer's until someone has passed. That's not true anymore, and we have ways of seeing the structural changes that result from Alzheimer's disease on the brain, in the brain with imaging, as well as with other types of lab testing now. So I'm going to abbreviate Alzheimer's disease as AD. If you see that on the slides, that's what that means, okay? So as Alzheimer's progresses, all of these system failures, the glucose, the metabolism, the amyloid, the tau, the cells breaking down. Think of it like multiple systems breaking down at the headquarters of who we are. But the failure of those systems leads to structural damage. And this can present with memory loss, disorientation, language changes, behavioral changes, all of those symptoms of Alzheimer's that we talk about all the time with our doctor and over at Insight as well. And you'll see it actually structurally changes the brain. So see that last picture in the panel here that I've got up on the slide? It causes brain cells to shrivel up and to shrink and to die. So this is what atrophy means. Alzheimer's disease has specific patterns of atrophy, where some areas of the brain are actually shrinking. Now, some of you have heard me say before, every brain is allowed to shrink over time. As we get older, our brains do get smaller. But when I see specific areas of the brain that show more atrophy, more shrinkage, then I know that there's something going on in those cells that's not supposed to be happening, because that one specific spot is shrinking more than I would expect. And we can't see that protein or plaque on MRI, just regular MRI is not how we diagnose it. So it makes me wonder though, MRI is the first step to figure out what's going on. Then from there, we got to zoom way in to say, what is it that's going on inside of the brain cell, around the brain cell, that's causing that area of the brain to dysfunction? It's kind of like when we make a batch of cookies and it doesn't taste good at the end, and we got to go backwards and figure out, did I leave out the sugar? Did I leave out the egg, the batter? Did I mess up on the oven preheating? What went wrong? Sometimes it's going to be multiple levels of system failure to lead to a bad batch of cookies. Okay, I want you to think of it that way. Another thing I want to make sure we understand, Alzheimer's disease is just one cause of dementia. So if you've been diagnosed with dementia, mild cognitive impairment, doesn't necessarily mean that the problem in your brain are these amyloid plaques and tau tangles. We have tons of other proteins and plaques that unfortunately do build up and cause disease. For example, alpha-synuclein is a protein that can build up in the movement centers, and it can cause Parkinson's disease. There are other tau tangles, tau proteins, there's prion disease. There's lots of other rusty parts that can develop. Sometimes it's because of the aging process. Sometimes it's because of our exposures, our head injuries, our genetics. Whatever it is, our brain is susceptible to damage, just like a car can develop rust under the hood. Okay? This does not mean that this is normal. Alzheimer's is not a normal part of aging, but it is something that is discernible. We can see it. There are proteins, there are tangles, and there's resultant damage from it. Okay? So now what do we do about it, right? We've isolated the problem. We've said, hey, that's the problem. That's what causes Alzheimer's. So what do we do now? Now we've discovered over the last couple of years that there are monoclonal antibody medications that can actually target or tag the amyloid plaque and tell our immune system, that's the bad guy, let's get rid of it. Now, prior to 2021, which is when the first anti-amyloid medication aducanumab got approved, you'll see that in the middle of the screen, that one is no longer on the market. But prior to that, we actually had tons of anti-amyloid research. For 50 years, probably we had been researching it, but none of it really made it to market because of side effects, serious side effects. We'll talk about those side effects in a few slides from now, but these therapies are not just pills. These are commitments, they're treatments, but they are disease modifying. So you might hear that in the news or articles that you're reading. This is the first disease modifying therapy for Alzheimer's disease. Other folks might be on, for example, Aricept or galantamine, or they might be taking a mood medicine like sertraline or Lexapro. Those are excellent choices to help with the symptoms of Alzheimer's disease, because Alzheimer's disease, remember, can cause language change, behavioral change. So the symptoms might improve with a medicine like donepezil or galantamine, but those medicines do not target amyloid. That's why this is the first class of medicines that are disease modifying, actually changing the disease process. You'll notice on this graphic on the slide that there have been a couple of other anti-amyloid therapies that have been FDA approved or accelerated approved. The first one that came out was aducanumab. Aduhelm came out in 2021. It is now no longer offered. The data that was published with that medication was a little bit expedited, and there wasn't a whole lot of consistency in the way that it was reported, so it didn't have as much backing. Lecanemab was the second medicine to be released, and you'll notice that the targets for lecanemab are actually different from the tags that donanemab, which is what we're going to talk about today, target. So donanemab is the most recent medication on the market, Kisunla, and it targets amyloid plaque, the end of this cascade as well as one step before. Now, let me remind you a little bit about amyloid. So amyloid, we have these little tiny protein products here, the monomers. They start to clump together because they're misfolded, and they form oligomers. And then the oligomers can clump together, and it just starts getting into a sticky tumbleweed. And they keep forming more and more fibrils, protofibrils, until eventually it plaques together. Now, research is suggesting that there are multiple steps, multiple of these products that are toxic to the brain, okay? But amyloid plaque is what we can visualize and see, and that's the one we were trying to get rid of with donanemab. Now, if we get rid of amyloid, it does not necessarily cure Alzheimer's disease. Oops. Okay, my lights went off for a second. I'm back now. It does not necessarily cure Alzheimer's disease, and here's why. Remember, amyloid was just the end of a giant cascade of changes that are happening in the brain. Let me go back a few slides. Do you remember all of this change that's happening in the brain? The brain is shrinking. There's all these inflammatory markers, and the blood cells are breaking down, and the way that we're metabolizing glucose changes. So it's not just amyloid that's involved, and removing amyloid is often the trigger, but it actually doesn't reverse all of the damage that's already been done. This is important to understand because these medicines, anti-amyloid medicines, are still not a cure for the disease. We're not going to have our memories come back, but they can slow down the progression of Alzheimer's disease. They can slow the declines associated with having Alzheimer's disease. So let's jump into what it does, okay? On July 3rd, so about 2 months ago now, the FDA approved, this is not a research drug, this is not an experiment, this is FDA approved donanemab, Kisunla, for people with mild cognitive impairment or early stages of dementia due to Alzheimer's disease. Now you'll notice it has to be due to Alzheimer's. If there's no amyloid in the brain, I could give you this medicine all day long. It wouldn't do anything for you, right? If your memory loss is because of sleep apnea or because of depression or because of something else, this is not an effective treatment for you, okay? This is also not a good treatment choice for folks that are kind of later in the disease process. I want you to imagine this protein buildup, amyloid, like plaque on your brain, okay? If you can imagine plaque, sticky plaque on your brain that's stuck and damaging brain cells and blood vessels. And now I'm kind of peeling away that plaque from the brain. That's what this therapy is trying to do, right? If I'm peeling away the amyloid from the brain, then you can imagine that the underlying tissue is gonna be more susceptible to bleeding and to swelling. Those are things that are going to be higher risk if that plaque has been around for longer. Doesn't that make sense? So if the plaque has only been there for a year, 6 months, perhaps taking it out, it's still soft and squishy. But if something has been stuck there for many, many years, causing a lot of dysfunction already, then this is not a good choice to try to dig it out of there. What we do know is that if we are able to catch the plaque early, where there is not so much tau. Remember, tau is kind of further along in the chain. When cells are broken down, they release tau tangles. So in a low to medium tau population, that means in patients that were in early stages of this disease, delivering this medication or treatment with Kisunla is actually an effective way of slowing down decline by about 35%. So if you take a look at this chart here, the gray line is someone who was not treated with this medicine, placebo. They just got something else. You'll notice that over the course of 12, 36, 52, 76 weeks, their scores in their independence and their day-to-day functions do decline over time. Because Alzheimer's is not just a disease of memory, right? It also affects the way that we can do our daily functions. So as Alzheimer's disease progressed, their ability to remain independent in daily functions also declined from baseline, okay? But folks that were treated with this medicine, with Kisunla, notice that their rate of decline, their slope of decline is slower. So that means they stayed in the earlier stages for longer. They did not progress onto the next stages as readily. 35%. Now you'll hear all kinds of numbers. They'll say, this is going to slow down decline by 6 months to a year. That's a number I like to use when I'm talking with my patients. That if you compare one person who's been on the treatment and one person who has not been on the treatment, in about 18 months, the person on the treatment is going to look about 1 year younger in their abilities to care for themselves. If you look at the actual scores on cognitive testing, they are reduced, they're better, or I'll say they are stable for longer. But often the numbers on cognitive testing, whether it's a MoCA or an IDRIS, which is a scale that they used in this study, often don't translate that directly to functional independence. So that's why I like describing it like it's a decreased slope of decline. When you think about that, 35% slowing in decline, okay? That means the earlier we get to you, the earlier we start treatment, the better, okay? But like we kind of alluded to earlier, and as I'm sure you guys know, Kisunla is not just a pill that you would take every day. This is actually an infusion therapy, very similar to someone who's been on chemotherapy, for example. You would go into an infusion center. It's about 30 minutes for the infusion. There's going to be a nurse there. You get this infusion once a month for about 6 to 18 months. That's a range because we can actually stop Kisunla therapy at different points in treatment, and I'll talk about that in the next slide. But it's important to realize that as an infusion medicine, we're signing ourselves up for a therapy. This is not just a pill that we're going to add on to our pill box. This is something that really changes our lifestyle a little bit, because we're going to need to be able to drive to this infusion center or get a ride to this infusion center, come home and be ready to be monitored if needed, because it's a big deal. And just like chemotherapy, where it can have a lot of side effects, these medicines can have side effects too, okay? So remember, while not a cure to Alzheimer's disease, because that amyloid builds back up, slowly but it does, Kisunla can delay declines in independent functions such as using the phone, keeping our appointments, selecting appropriate clothing, completing our chores. That's where we see that Kisunla shines. Okay. Now, when I said that 6 to 18 months, this is what I mean. Treatment with Kisunla is really good at what it needs to do, which is getting rid of amyloid. It's actually very effective at removing amyloid from the brain. You'll notice that at 18 months, average 84% of people had complete amyloid reduction, okay? Gone. But it does reaccumulate, and getting rid of amyloid from the brain doesn't change the fact that the brain still has shrunken, blood vessels are still damaged, all of the other things that went wrong are still there. That's why we still have symptoms. That's why we don't go straight back into Einstein mode, right? We got rid of the trigger, the bad guy. We do still have declines, okay? So it's really, really good at getting rid of amyloid. We can see it on PET amyloid imaging, which is a specific type of scan that actually lights up the amyloid plaque in the brain. So what Kisunla offers that's very unique, the only one on the market to do this, is we can stop treatment with Kisunla earlier than 18 months if we can show that amyloid has been cleared to a specific minimal number. Okay, so we actually have numbers, centiloids, which are like how dark or how bright the amyloid is shining. And we can actually measure how much amyloid is removed and how much centiloid difference there is on PET imaging. So you'll notice that at 6 months, 17% of patients were clear. At 12 months, nearly half of patients treated with this medication were clear of amyloid. And at 18 months, we're looking at almost 70%. So if we've got to a PET scan level of, okay, pretty much no amyloid left, we've met our marker, our benchmark, we can stop Kisunla at 6 months. We can stop it at 12 months. We can stop it at 18 months. Okay, this is important because it lessens not just our lifestyle commitments and having to go to the infusion center, but shortening the duration of treatment also lessens the risks of treatment, right? Because we're not exposed to the medication for as long. And I keep alluding to these side effects. What am I talking about? This is what I'm talking about. I'm talking about ARIA. Now, anyone getting an infusion medicine can get fever, chills, kind of reaction on the skin. You might feel kind of malaise and out of it the day you get an infusion, and that's okay. That usually gets better with Tylenol or Motrin. But the more serious side effect to look out for any anti-amyloid agent, by the way, not just Kisunla, is a serious side effect called ARIA. ARIA is actually an abbreviation. It stands for amyloid-related imaging abnormality. Kind of a funny moniker, but here's why. It's an imaging abnormality where the brain can have spots of swelling or bleeding, evidence that there was amyloid there and now it's gone. Remember my analogy of removing plaque from the brain? If we're draining out, sucking out the amyloid, the underlying tissue will show signs that someone was digging in there. Bleeding spots, swelling. Now, if I had a bruise on my arm or on my leg, turned black and blue, and then within a couple of days it gets better, right? If we have bleeding on the brain, it causes a lot of brain symptoms. So it can cause worsening confusion, disorientation, headache, dizziness. It depends on where the bleeding happens. Sometimes it can cause vision loss. But more seriously, if there's enough bleeding or swelling, it can actually irritate some of the electrical circuitry of the brain and cause seizures. It can cause big strokes because blood on the brain is akin to a stroke. And in worst case scenario, it has caused or been related to death. Okay, so this is not a mild side effect. This is a very serious side effect. How did this even get approved to be on the market if it can cause death, right? Here's how. ARIA is serious, but it's only symptomatic in 6% of people that were treated with Kisunla. Most of the time, it's an asymptomatic finding on imaging. That's where the name comes from. Amyloid-related imaging abnormality. That means we as clinicians, as doctors, we got pictures, we got MRI after MRI, and we noticed changes, and we're like, oh, that's a spot. Oh, that's swelling. And I'll show you some of that. Here's a picture of it, actually. But the patient looked great. The patient, the person getting the treatment, actually didn't feel a thing. Asymptomatic ARIA for the most part. Now, if you take a look at this MRI, these are two different ways of looking at an MRI. The top kind of lighter gray is actually a way of looking at bleeding. I want you to notice where the arrows are pointing. The first panel, the first picture, is a bleeding sequence from baseline, from this patient's just normal MRI. And then the second panel, we're looking at 19 weeks after Kisunla therapy, and you'll notice that there's some black spots. See that black spots? Those are actually iron depositions that suggest tiny spots of bleeding. On another sequence, that actually shows up as a little bit of swelling around the area. See the kind of white fluffy around the same areas that the arrows are pointing to in that panel B in the middle? But by 28 weeks, that's what the last panel is, those fluffy spots are pretty much gone. There's no inflammation. I see damage. I see the results of iron that's been deposited of former bleeding. See that little snake looking thing right there? That's iron that's gotten deposited. But overall, the brain did very well at just kind of fixing itself. It got swollen, it got bruised, and the patient didn't feel anything. But we as neurologists, as radiologists, we're looking at it, we're like bleeding spot, bleeding spot. And we notice it and we call it an amyloid-related imaging abnormality. Now, don't get me wrong, if it's serious, and we have to rush to the ER, possibly get admitted to the hospital, get MRI scans. We might need ICU level care depending on what symptoms we find or we have, but that rarely happens, okay? Patients do not feel symptoms 70% of the time, okay? Now, asymptomatic ARIA occurs 25% of the time, 25 to 30% of the time in treated patients. I'll let you know there are certain risk factors that actually make ARIA show up even without a medication, okay? So even without therapy, we can have those tiny spots of bleeding just out of nowhere from walking around and living life. We can have microhemorrhages and swelling. There's some people that get that, and I'll tell you about those folks. There are protocols in place for everybody that is on an anti-amyloid infusion therapy. We carry around a little safety card. We've got a flag in the patient chart that says, hey, I'm on Kisunla. I need everyone to pay attention before they prescribe another medication or try to give me a blood thinning agent because I'm on a very serious treatment. Very similar to our patients on cancer treatment. We've got a flag that tells them exactly what kind of cancer treatment they're getting, right? So see how this is kind of a bigger deal than just a pill that we take every day? So it's once a month going to an infusion center, but also with this high risk profile. We do our best to keep us safe, to look out for it. We have regular routine MRIs, we have regular routine PET scans, and we try to get you off of the medicine as soon as the amyloid is cleared, okay? Now, if we do have a serious side effect, big bleed, big stroke, seizures, there are guidelines for stopping the medicine, if we can continue the medicine, if we just need a pause on the medicine, and then we can pick it back up in a couple of months. All of that has been well researched. And it's not just the last couple of years that we've known about ARIA, by the way. Remember how I said we've been trying to figure out amyloid stuff for the last 50 years? The reason why none of it got approved before is because of ARIA. We didn't know how to get around this situation, but we knew it happened. We knew that if we tried to remove amyloid, it causes ARIA. So we as scientists and as doctors, we've been working on this problem for a while, and we've finally got some solutions where ARIA is mostly asymptomatic, okay? This graphic here has 11 people getting treatment. That's what all of these little airplane seats, human beings here, that's what all of the white people are doing right here, okay, these outlines. You'll notice that all of the gray shaded people, those are the folks that got asymptomatic ARIA. And then of those people, or within those people, you'll see that only really 6% of them had symptoms from it, okay? That's ARIA. We have to know about ARIA. It's a very important side effect. Now, there are specific risk factors that can increase the risk of ARIA. So remember, it's bleeding and swelling in the brain. If you have a tendency to bleed, or if you're on a blood thinner, it makes sense that you're going to be more at risk for ARIA, right? If you're already taking strong blood thinners, it's actually a contraindication to use this medicine. And when I say strong blood thinner, I'm talking anticoagulant medicines like Eliquis or warfarin. There are people who take baby aspirin or Plavix. Those are actually not associated with too much of an increased risk, okay? None at all if you look at the data. So what that means is we have to have a sit down, heart to heart with our doctor and really say, what are my risks of ARIA? Am I gonna get benefit from starting a therapy like Kisunla? And that's so important. We might not do this kind of conversation with any other medicine that we start, but these therapies in particular are very important to have that risk benefits conversation, go through our med list, go through our medications, our medical comorbidities, because this can be life-changing to have one of those side effects. Because Alzheimer's disease is a slow, chronic illness that often stays in the background. Yes, it causes declines, but it's not something that happens so quickly. Versus having a headache or a stroke or a bleed in the brain can happen very quickly and change our life very dramatically. I want to tell you about one gene that we check for before starting these therapies. It's a gene called ApoE. ApoE is a gene that can have different alleles. There's a version 2, there's a version 3, and a version 4. The one that's associated with increased ARIA, as well as increased Alzheimer's, is ApoE allele number 4. So you get one copy from mom, one copy from dad, and if both copies are 4, type 4, that increases your risk of bleeding and swelling. If you have only one copy and you're protected with a 2 or a 3 on the other side, increases your risk slightly, but not too much, okay? Every clinician, every provider is going to deal with this risk factor differently. I personally, I hesitate to give people these therapies when they are ApoE4 because that's a big risk to take. There weren't a whole lot of ApoE4 gene patients on the studies and the trials, and it is associated with increased side effects. So that's something that I personally, as a clinician, I'm going to sit down and tell you, listen, is this worth it? It's not a no-go, but I'm going to have a serious conversation with you, okay? Bleeding disorders, anticoagulant medicines, we talked about that. Also, any recent major stroke or blood vessel disease, that means if you've already got really bad blood flow to the brain, your pipes, the blood vessels to your brain, are already friable. What I mean is they're already kind of weak and vulnerable. They're more easy to break. They're crunchier. They already have leaky spots. If there's already a risk of blood flow to the brain that's really bad, I don't know if it would be worth it to give you a strong medicine that can cause worsening bleeding and swelling. And you'll notice this chart, this graphic to the right, actually talks about what ApoE does to our brain and our brain cells. It changes the way those pipes are made, the blood flow pipes. It can cause an increase in tangles, cause increases in brain atrophy, and it reduces the amyloid clearance. So overall, ApoE is not 100% guarantee that you're going to get Alzheimer's, but this is an allele that makes you a little bit more vulnerable to this disease process. It changes the way that your blood vessels work. Okay? Almost done. Sorry, I know we're going through a lot of science here. Hope you guys are still with me. Just a couple more slides. So overall, Kisunla is an effective FDA-approved medical therapy for the treatment of the early stages of Alzheimer's. So it's got risk factors of ARIA, but it is FDA approved if we can start treatment early. We have to prove that you have Alzheimer's first. This is not something that we can prove with an MRI. This is something that's going to require a physician to diagnose you and prove amyloid. We prove amyloid with PET amyloid, which we've talked about a little bit today. We can also prove amyloid with spinal fluid that measures the amount of protein that's building up in our spinal fluid. Spinal fluid is actually the same fluid that surrounds our brain. If you look at this MRI, for example, see the dark spots in the middle, those are ventricles. Those ventricles are circulating jelly that keeps our brain well cushioned so we're not rattling around in our skull. That's the spinal fluid, cerebrospinal fluid. It actually goes down and it circulates into our spinal cord and our lower back. So we can measure the cerebrospinal fluid with a lumbar puncture or a spinal tap. We can look at how much amyloid is there as well. Okay, those are the two options for confirming amyloid 100%. I say this because there are blood tests that are getting way better. There are a lot of good blood tests that predict amyloid ratios very well, but a blood test is looking at a blood biomarker, right? Just as a lab draw. It hasn't yet 100% confirmed the level of amyloid in spinal fluid and in brain tissue. We're getting there. Believe me, I think we're going to get there soon. There's a lot of really good research going into blood work, but it's not 100% confirmatory. And if I'm going to start somebody on a therapy that's got risks like this, I want 100% confirmatory. So we're going to do PET or spinal fluid. Okay. Another thing I wanted to tell you about confirming Alzheimer's is sometimes we can have amyloid and not have Alzheimer's disease. So actually, in 30% of people that have amyloid, they have no signs of Alzheimer's disease or cognitive dysfunction at all. Remember, it's a waste product, it's an exhaust pipe, and you can have it light up on PET scans. But if you don't have a clinical syndrome, that means if you don't have the forgetfulness that fits Alzheimer's disease, plus the biomarker, then you don't have Alzheimer's disease. You might have amyloid in your brain. I could have amyloid in my brain right now. I've never had a PET scan. But if it's not causing symptoms that look like Alzheimer's disease, then it's just hanging out in your brain. Kind of like, if you've ever gotten an MRI of your back or of your knee or something for some reason, and they accidentally discover that you've also got arthritis there or a disc bulge, and you're like, well, that's interesting that it's there. We're not going to go to an orthopedic surgeon and say, hey, fix that disc bulge. I accidentally found it, if it's not causing us problems. Now, if you got that back scan because you've got shooting pain in your back and sciatica and we want to get it fixed, and then we found a disc bulge, that makes sense, right? Disc herniation, back pain, I want to get it fixed. That's how I want you to think about this. If we just go around and scan everyone for amyloid, we're going to start treating people that don't actually have symptoms. This is a very interesting part of neurology and neuroscience and cognitive neurology in particular. We're all like, should we start treating asymptomatic patients that have family history of Alzheimer's then? And we just found amyloid? What if they never developed Alzheimer's? What if it was just hanging out in their brain for the rest of their life and they were able to stay healthy enough to fight it off? Then did I just expose them to a medication for no reason? These are all the kind of philosophical things that we're thinking about as we get cooler and cooler scientific advances in this field. Now, I went off on a tangent there. What I really wanted to tell you is how this medicine gets covered. So Kisunla, effective, FDA approved for Alzheimer's disease, that is Alzheimer's biomarker, Alzheimer's cognitive profile. You need to have both. We can't just haphazardly get it. It is currently covered by Medicare. The clinician you're working with, the provider you're working with, is going to register you onto a big database of every patient who is on Kisunla. That's important for us to know how this medicine is working nationally. If there are side effects, it's like a drug monitoring program. Medicare wants to know this because on a national level, dementia is becoming more and more extensive and using up more and more government resources, right? Home health aid, nursing facilities, etc. The government wants to know, what can we do to help? So they're keeping tabs on people that are getting disease-modifying therapies, and that's part of how we get this medication covered by full Medicare. If you have Medicare Advantage or any other insurance, private insurance, commercial insurance, they're catching up. There's no guarantee. I always just work with the company. So Eli Lilly is the company that makes Kisunla, and they have a fantastic patient support team that will look into your financial situation, see if we can get you any patient vouchers, see if your insurance company did turn around and change their policies. They have a whole finance team to work with you through this. And every week, every month is a little bit different. Okay, so I have no 100% guarantee except with Medicare. I know Medicare covers it, but most other insurances, I'm like, let's try and let's see what happens. Let's see what we can get for you. Because there are patient vouchers, there's benefits assessments, there's all kinds of things that they are able to help with if you qualify. Now, Kisunla itself, the medication itself, is around $2,000 a month, is the estimates that I have heard. Every patient situation is going to be a little bit different, so we're going to have to work with you and work with the infusion center. because it's also going to cost to have a nurse give you the medicine, set up the IV, all of that stuff too. So $2,000 a month, once a month treatment, right? However, if you remember from a few slides ago, Kisunla is monitored with PET imaging. Currently, PET scans are only approved one PET amyloid. It's a specific type of PET scan, not a regular PET scan. PET amyloid has only been approved by Medicare for one a year. If we need to do at month 6, at month 12, at month 18, we might have to work on getting our insurance to cover better. Otherwise, those PET scans are actually more expensive even than the medicine. They're around $4,000 to $5,000, depending on the radiology center. So it's a costly treatment, and a lot of it is not free. I don't want finances to be a barrier for anyone. Unfortunately, it's a realistic part of this, though, right? So this is a conversation, again, that should be included in our risks and benefits conversation, because we know that it works, gets rid of amyloid. We know that it slows down progression of the disease, but what about all of these other variables? What about our lifestyle change? What about driving to and from the infusion center? What about perhaps the stress and anxiety of being on a therapy that can cause serious side effects? All these other things play a role in this decision, and that's going to be between you and your doctor. Okay. But here's the data that we have. And I did want to share a couple of other slides of other data that's been cooking, because amyloid is just one target. Remember all of the other glucose and epigenetics and tau and endothelial dysfunction? Look at all of the research that's cooking. This is just 2024. All of the research trials that are in phase 1, phase 2, phase 3, all of these drugs that are looking at different targets. Some of them are biologics, that means disease modifying. Others are looking at small molecules like insulin regulation or inflammatory cytokines. Others are looking at symptom treatment. We have so much in the works, so much in the work. Are we going to reduce inflammation? Are we going to reduce tau? Are we going to work on our lifestyle? There's so much in the works, and we don't know which one is better than what. Because even within the anti-amyloid world, we saw Kisunla is not our only option. There are no head-to-head trials that compare one to another and say one infusion is better than another. The way that the trials were made were completely differently set up, actually. So it's not fair. We just don't have that data yet to say this one compared to this one. But know that there is data coming. Look at all the research that's going to be produced soon. Okay. One thing I do know is that prior to 3 years ago, 4 years ago, all we had really for Alzheimer's is symptom-based treatment. All of this stuff is fairly new, right? And we have hundreds, if not thousands, of papers that are published that demonstrate effective treatment of Alzheimer's symptoms, prevention of worsening of symptoms, if we can keep our brain healthy. Remember, it's a cascade of events. One thing led to another, led to another. It's not just the ApoE gene. It's not just the presenilin gene or one of the other Alzheimer's genes that leads to your disease. It's also all those concussions we had, all those burgers we ate, the soda, that one time we were exposed to that one toxin, the stress, the sleep apnea. All of it adds up to create a disease. It's never just one thing leads to another. So as much as possible, if we can equip our brain to fight this, we do better. And this is how we equip our brain to fight any disease, right? Being social, staying engaged, exercising our brain with challenging, stimulating activities, managing stress, having friends, staying physically fit, sleeping well, eating well. So I wanted to end on that because this stuff works. We have decades of research that shows this. Is it going to prevent Alzheimer's? No. But is it going to make your life better? Is it going to lessen the burden of the disease if there is a disease developing? Yes. Okay. So if there's a disease developing and then we start to eat right and sleep well and do those things, you are going to have a better time than someone who does not do these things. And that holds true even in moderate and severe stages. And guess what? Most of the stuff on this slide is not associated with super risky side effects. This is also not one or the other. It's not like we have to choose this slide over Kisunla, right? We can do this as well as a disease-modifying therapy. So that is the end of the slide deck that I have. So let me get off this slideshow sharing, and then I want to open up to questions. I hope that
We have a couple. If anyone has any in addition to the ones I'm going to read off to her, please feel free to put them in the Q&A box. Reminder, we did record this. She's going to give me a copy of the PowerPoint as well for us to put up on our website after. So first question, I've been referred to for treatment for leukemia. I am in the early stages of Alzheimer's at the age of 56. I haven't started the treatment yet. Should I consider Kisunla instead?
That's going to be a personal decision. Remember, we don't have any head-to-head trials that say Leqembi, which is lecanemab, which is that other medication that's on the market. It's been out for about a year now. It came out last July. Last July. So both of them target amyloid at different spots. Is one better than another in terms of comparing the two? We don't have that data. We just don't have that data. But what I can say is there are major differences. Leqembi is twice a month. Kisunla is once a month. Leqembi is an 18-month set therapy. Kisunla can change. We can do 6 months, 12 months, 18 months, depending on how you do on the amyloid treatment, okay? So it is going to be a personal discussion. Some of it is going to be guided by non-medical things. Like, what if we just can't get a ride to the infusion center twice a month, right? What if it's very far away from us? Others might be guided by financial considerations. Leqembi is about $26,000 a year, give or take. Leqembi, because it has been out for about a year, there are probably different insurance coverages now for Leqembi. These are all things to consider. They're realistic things to consider, and that's something that you should discuss with your doctor.
Thank you. How do we test for plaques and tangles?
So amyloid is proven with two different measures. There's the PET amyloid that lights up amyloid. And then there's a spinal tap that measures amyloid in our brain. It actually measures how much amyloid. And there's a ratio for how much amyloid to how much tau. We also have measures of tau in spinal fluid, as well as tau we can measure in serum fairly well now. Now, tau is kind of a downstream effect of amyloid, so I don't use tau as a marker of success for if you have Alzheimer's or not. We use amyloid, and then we expect to see tau, but amyloid is the one that we want to confirm to see if it's Alzheimer's or not.
Thank you. How should someone think about the pros and cons of getting on this treatment, given this and other considerations?
I think the best way to think about it is this is a chronic progressive illness. I cannot change that fact. Most neurologic illnesses do not have a cure, okay? We like to pretend that we're heroes, that we're like superstars and we can get rid of this stuff, but it's not. It's a chronic progressive illness that, by the way, didn't just show up last week or last month when you got your diagnosis. It's been there for years, possibly. These amyloid plaques and stuff change in our brain kind of in the background for a long time. All that to say, if things are changing in your brain, if it's a chronic progressive illness, if this progression of the disease is going to cause significant changes in your lifestyle or in your family dynamic, then we should see, do I want to take the risk of getting treatment for it? If you are already super well tucked in, your family's got you, you've got a backup system, and you don't want to take that risk, you've got all the systems in place already to catch you if you fall. It's a chronic, slow, progressive illness that often lasts 10 to 20 years. Alzheimer's, 10 to 20 years is a long time. There are countries around the world that are not even approving these therapies because they would much rather put their funding into lifestyle modifications and prevention and early detection. For example, Europe, most European countries are not offering this therapy at all because they're like, we're just catching the end stream of this. We really should be focusing on how do we prevent, how do we keep ourselves healthy. So think about it that way. Long-term chronic illness. Getting rid of the amyloid seems to slow it down, but it carries with it some risks. Am I tucked in and safe in my family life situation, or do I need to make some changes now? That's how I would approach it.
Thank you. If we're worried about a family member who might have dementia, would they see someone like you, and are you accepting new patients?
I have a really long wait list. You might have to wait until like January or February to get in with me, but I am accepting new patients. I work out of Inova Fairfax and Inova Alexandria. We also have several other cognitive doctors, neurologists who see cognitive change, as well as several other neurologists in the area that might be able to help too if you can get in with them sooner. The more discerning question is which of these doctors are actually infusing medicine, because that's not as broad. So here at Inova, we have like 3 or 4 different physicians that infuse these therapies. That might not be the case at a community hospital or kind of at a smaller spot. So you might need to get a specialist referral. If you are worried about cognitive change in your loved one, one of the first things I always say is they might not realize it. The brain has this awesome ability to protect itself. It's going to stay the boss forever. So if we are missing medicines, if we're making mistakes driving, if we are missing appointments, the brain is going to think we're not doing anything wrong. I'm doing a great job. So first and foremost, let's make sure your loved one is safe. Is there anything in their food, in their water that might suggest they're getting sick or losing weight or their house bills have been unpaid? That's the first thing to verify, and that should happen before waiting for any doctor. Okay, let's make sure everybody is safe. And it's no fun to go, nana, nana, boo, boo, you forgot your bills again. Okay, that's not fun. The brain doesn't realize what's happening. Rather, it's, hey, mom, I just wanted to check in and see how you're doing. Looks like we've got some things that I could help you take care of. Let's do this together. Or I'm having trouble with this. Can you help me with this? And just get some of that stuff sorted to keep us safe and then get a referral to a doctor.
Perfect. Thank you. Are there treatments that can be used with moderate stages? Thank you for your answer.
Yeah. Moderate stages are usually symptom-based medications and treatments, and that includes not just meds. So if we are, for example, sundowning and disoriented by day and night, I've got some great options to regulate the circadian rhythm, make sure that we're sleeping at night and awake during the day. If we're so tired and fatigued and not interacting like we should, I've got some great medicines to help you stimulate and stay active and awake. If your moderate stages of dementia are showing more signs of mood change or behavioral disturbance, we can treat that as well. In terms of disease-modifying therapies, there is not a disease-modifying therapy that is fully FDA approved for moderate stages. They're symptom-based. You'll hear about it or see about it. For people that say, I can control sugar or I can control this cytokine or that cytokine, and it seems to slow down dementia. That's not true. It's being researched. Remember that big pie chart. It's being researched, but it is not, it's not approved yet. Does it help? Probably. On a scientific basis, it makes sense to me, but it's not out yet.
Perfect. Thank you. We have a great presentation. You are amazing and easy to understand. Thank you for working so late. Next question. Are there any drugs that target tau plaques or will be coming out?
There are actually drugs that do target tau. They, again, it tends to be European studies, but there are companies, infusion centers and research companies in this area that actually do anti-tau infusions too. So they are there, but they are not approved. Sorry, we're getting more data. It's part of that pie chart, but it's an even later stage of neuronal death than amyloid. So that's why we're trying to catch it a step ahead. For example, tau can build up in our brain, even the specific phosphorylated tau 217 and all those things, it can build up if we even have a really bad meningitis or if we have a really bad head injury, for example. It can interfere with our tau measures. So it makes sense, right? Neuronal death, tau, why should we target that when maybe we can catch it a step earlier? But there is a lot of research in the tau space too, even locally, by the way, not at Inova, but locally there are centers that do that.
Thank you. Have you seen Leqembi patients transition to the Kisunla?
Um, it's not against the rules. I have not had any of my Leqembi patients switch, I personally, but Leqembi's only been out a year and Kisunla's only been out a month and a half now. So I don't have any personal data of that. It is an option. There is no data that says you can't do it. I will say, it's a situation that we have not researched. We have not researched what happens if you've already been digging around in amyloid in your brain, and now we do it again with a different agent. We just don't know. It's a new field. It's kind of like, what do we do if we give this to a pregnant patient? We don't know that data either. I just don't have that data yet.
Thank you. We've been warned that the wait for getting into this treatment can be very long. How much wait should we expect?
It depends on the provider and how quickly we can find you an infusion center. I've had a patient start in 2 weeks. It really just depends on how quickly we bug insurance and get all the paperwork done. There's a packet, there's like 5 pages of paperwork I have to fill out for Kisunla. It goes to the Eli Lilly patient support services. I also have to make sure I've got an infusion center lined up for you. If we've got all of our ducks in a row, we can get you starting on treatment within a month. But you should expect, like, there's a couple of things I got to check, right? I got to make sure you actually have Alzheimer's. I got to make sure you're a good functional fit. I want to check your ApoE. I want to have a good, long, serious conversation with you. Like, we got to have all these things in place. And so I think the wait to get in to see a doctor is probably longer than to start treatment. But you can help yourself out and get your primary care to order an MRI, maybe to order neuropsychological testing. Those are two pieces of data that will help me, maybe even get ApoE tested while you're at it. Those are data that I can use already to help expedite this if it's going to be a wait to come see a provider, a specialist.
Thank you. At what age should a person get testing if they have no symptoms, but they have a family history of Alzheimer's?
Why do you want to know? I'm just kidding.
Yeah.
That is a question to ask, though. Why do you want to know? Do you want to know? Is that something that's going to be 100%? No, it's not. There are some genes that are 100% going to show up. Like, for example, the breast cancer gene. That's a good one to check, because if it's running in your family, there's something that's running in your family. It's going to show up. This one is not 100% guarantee. Does it increase your risk? Yes. Is there anything we're going to do about it by knowing, besides worry and lose some sleep and then subsequently increase our risk of cognitive decline, right? No, because these therapies are not approved for pre-symptomatic disease. That's probably the next thing that's going to come out, by the way, pre-symptomatic disease. But right now, they are not approved for that. They're approved for mild cognitive and early. So I would think long and hard about getting it tested. I would more likely or more strongly suggest, if you are having cognitive change, better to see if it's just regular old I'm stressed out and I'm not sleeping enough change, or if this is the first step in something that might suggest a progressive illness.
Yeah. And for instance, Insight, we have memory screenings monthly. September 16th, we're going to be at the Wellness Center for Older Adults, and there's appointments open, and you can sign up there and do the quick MOCA, and you can get a baseline. That's an easy way. That's something that's not going to give you definitive answers, but I think that's, a lot of people have done that as well. Okay, our next question. So do you need to have the APOE44 marker along with the amyloid plaques in order to be approved?
I would prefer you not have the ApoE44 because that increases your risk. So you can also have ApoE2 or 3, but it is necessary. It is strongly suggested that we get that gene tested. And I'm pausing here because every doctor is going to be a little bit different, but a good doctor is going to have a thorough risk evaluation, and a thorough risk evaluation is going to include that ApoE gene.
Thank you. We have had this question is twice. If only takes if one takes the treatment is it's successful and the plaques come back, can they do the treatment again?
Ooh, I love this question. Okay. Should I let you guys in on a trade secret?
Ooh.
There's tons of stuff that's going to be presented in October. There's a big Alzheimer's conference in October, clinical trials, and there is data coming out that repeat treatment in a couple of years. Ongoing maintenance therapies are the way that we are going to treat this disease. So, is it good to just get ahead, get it all out, take a pause for a couple of years, wait for it to come back, and then repeat the treatment? Maybe that's one school of thought. The other school of thought is, what if we treat it like we treat multiple sclerosis or headaches or even Crohn's disease and just go in once a month and get a maintenance shot? There are subcutaneous injections coming out. There might even be an oral pill version of this stuff coming out. So it's cooking. We don't have anything definitive yet. I think the next big thing is probably Leqembi maintenance therapy, if I had to guess, but it's all a guess based on gossip.
So our next question is, would someone stop Alzheimer's disease medications like donazep
Donepezil.
thank you, before starting the Kisunla, or take it simultaneously?
Simultaneously, because that doesn't affect the amyloid at all, right? That's just a symptom-based medicine. As long as you're tolerating it, I'm going to continue both.
Perfect. And our last question, how long does one have to sit for an infusion treatment?
Kisunla is about 30 minutes. And they might watch you the first time that you get treatment just to make sure you're not having any reactions. One thing that I didn't mention, I don't know if I did, those ARIA reactions can happen anytime. It doesn't have to be within that 30-minute time that you're getting the infusion. It could be anytime in the next 6 to 18 months. So they're watching you really just to make sure you're not having the fever, chills, kind of that immediate infusion reaction. But over the next course of treatment, you're going to be watching yourself and making sure that you're not having stroke-like symptoms. And if you do, you're going to the nearest ER. We're not sleeping this one off.
Yeah. Perfect. Thank you. I just do a few housekeeping slides, and then if anyone has any questions while I do that, I'll be glad to bring those back up to her. As you see on the screen, our mission is to provide specialized care, support, and education for individuals in all stages of memory and cognitive impairment, their partners, and our community. Our vision, a community where those living with memory or cognitive impairment and their care partners can achieve the highest quality of life. And we are excited to say we have been around for 40 years this year. We just celebrate our anniversary. We provide care specialized in adult day programs for people in all stages of their dementia journey. So that is from early stage all the way to late stage. Connections, we build relationships and supporting care partners on their journey. And creativity, we have dementia experts sharing their knowledge and resources because every journey is unique. Upcoming events, you can go onto our website on insightmcc.org/events. On the 4th, next week, we actually are doing the 2025 Medicare updates. We are doing it in the afternoon at 4 p.m., not an evening one, but feel free to sign up for that so you can get all of the updates on all the new Medicare rules this year. And that is it. I don't see any more questions. Dr. Pauldurai, thank you so much for your time this evening. And for everyone that joined us, this is recorded. She's going to share her slides and we'll have them up on our webinars by the end of the week, probably.
Thank you so much for having me. I hope that you guys found this helpful. Please continue the discussion with your doctor, though. Ask questions, read articles, bring them in. We love to talk to you about this. Okay. Have a good evening.
Thank you.
Are we done?